So, good evening, everyone. Uh, Welcome back again to our series of Vertigo Talks. We started this Vertigo Talk series in September 2020, and we completed 12 lectures successively every month. And there was a gap of around last 6 months, 6 to 7 months. So, we will continue with this Vertigo Talks 2.1, and hopefully the whatever interesting cases which I have seen in past few months, I will start sharing, and we will begin this with just this. Today's talk is mainly based on central vestibular disorder, a theoretical information about how to differentiate central and peripheral vertigo, the vestibular disorders. So we'll begin with this. I thank Dr. Sriharsha and Sahasra Anti Foundation for giving me this opportunity to present, and we will hopefully will continue this every month. We will come up with a fixed schedule of every month, and we will continue that. So I'll just I have nothing to disclose, and I have taken consent from all the patients shown in this presentation. So this is the outline of my talk today. Uh, so I will just broadly discuss the organization of vestibular system. Then I will talk on the spectrum of central vestibular disorder. What are we dealing with when we say central? That means what? Like, which are the different disorders? Localization is central, but what is the etiology we talk about? Then we will discuss what are the different central signs and symptoms, and the golden question: how to differentiate central and peripheral vestibular disorder. That's a very important question to be answered whenever we deal with a patient of vertigo and dizziness. It's very important that we should be we should be aware about what are the things, how to differentiate, what are the red flags for diagnosis of peripheral vertigo. What are the red flags? Which red flags which will indicate you that it is a central disorder and not a peripheral. So now I'll discuss on the organization of vestibular system. Before going to that, I'll just would like to confirm whether my audio and video, everything is clear. Can someone write in the chat box so that let me see.
Yes, sir, you can go ahead.
Yeah, okay, great. So if we look at the vestibular system organization, see this, you are all aware that there is this inner ear. There are two parts. One is concerned with the hearing and one is concerned with the balance, that is vestibule. Then the vestibular nerves starts from the vestibule, that is superior and inferior division, and forms the vestibular nerve proper. Then comes the vestibular nerve enters in the pontomedullary junction and forms the vestibular nuclei. It relays all the information coming from the vestibular sense organ is relayed in the vestibular nuclei. So if we look at this organization, if the vestibule and vestibular nerve, they are definitely a part of peripheral nervous system structurally. But vestibular nuclei, although they are a part of central, structurally they are a part of central nervous system. Functionally, it is a part of peripheral nervous system because the impulses which are going till the vestibular nuclei are unaltered, like they are pure information coming from the. Once there is modification in the vestibular input, then it becomes a purely central. That's why although the vestibular nuclei are located in the central nervous system, the functionally if there are lesions, of course there is some modification of the signals happens in various nuclei in the vestibular nucleus complex. but until the root entry zone, from this root entry zone till the vestibular nuclei, it is pure vestibular sensation. So this is a very important thing. That is the reason why the central vestibular disorder can mimic pure like a peripheral vertigo, and that creates a lot of confusion. So if there is a strategic infarct in this area, demyelination or encephalitis, it can mimic like neuritis. It is a pseudo-neuritic presentation can happen. Next is the so this is the peripheral vestibular system. Function we can say this is a functionally a peripheral vestibular system, including the nuclei. And when the input gets altered, like that, there are changes in the input in the vestibular nuclei, or when they travel, like from the vestibular nucleus, they travel to the ocular motor nuclei through the ocular vestibulo-ocular reflex. It goes to the spinal cord by vestibulospinal tracts, and there is another reflex, vestibulocholic reflex, vestibulo-autonomic reflex. So these are various, the vestibular new signal from here goes to various systems, various autonomic system, limbic system, cortex, cerebellum, ocular motor nuclei, spinal cord, and these vestibular nuclei inform everyone in the brain. Like you just imagine the brain is a like one organization where there are different people working on different tasks. So the major function of the vestibular nucleus is to inform everyone that this is happening in the balance system, and like so that they can adjust the various outputs from their those structures, and they can adjust the balance. So these are the various functions we when we examine a patient in a any neurological patient. When it comes to a neurologist, we usually go through higher functions, cranial nerves, motor system, sensory system, and cerebellar function. Uh, this is the schema through which we go, and we examine the patient. And now I will let you know like how the vestibular system is connected to everyone. Now coming to higher functions, vestibular system is responsible for visuospatial orientation, and it gives the information about the spatial maps to the vestibular cortex, and there are other areas which are involved like parietal cortex. The vestibular system gives information regarding the spatial maps, uh, as well as the emotions like involved in the during the vestibular stimulation. So I think everyone might have enjoyed the merry-go-round during the childhood, or in the adulthood we go for theme park rides, these roller coaster rides. So vestibular system it can be a part of pleasure, like when we stimulate the vestibular system. uh, there are two ways how we can look at vestibular system. So it has intimate connections with the emotions, and during childhood, mainly we utilize this for pleasure. But of course, it can get involved in variety of diseases, and it can cause symptoms which can lead to a lot of emotional disturbances. Then comes the variety of cranial nerves which are connected with the vestibular system. The second nerve, one of the major function of vestibular system is stabilization of the vision. And there are a variety of symptoms which can happen because of vestibulovisual connections, which are called as vestibulovisual symptoms. And Barani Society has come up with the a separate classification of this group of symptoms, which I'm going to explain in the next slide. That is vestibulovisual symptoms through the connection between the vestibular nuclei to the third, fourth, sixth nerve nuclei. It controls the ocular movements. The ocular movements are controlled by the output inputs which are coming from the vestibular nucleus. It has connections with the fifth nerve nucleus. That's why, because of the connections between the vestibular nucleus and the trigeminal nerve nucleus complex, what happens is there are variety of things for example, in migraine. In general, we know that migraine can cause head pain, like headache, because of trigeminal involvement of trigeminal system. But because of connections between trigeminal and the eighth nerve, what happens is isolated vertigo can also be a manifestation of vestibular migraine. It is not mandatory that patient must have headache during the presentation. So that is the importance of connections with the of the eighth nerve with the fifth nerve. Then the regarding the seventh nerve, a relationship between the eighth nerve and the seventh nerve, they travel together in the internal auditory canal. That is the reason why in there are certain disorders where they can get involved, like for example in Ramsay-Hunt syndrome. In case of CP angle tumors, both can get involved together. Then the involvement of the tenth nerve, the vestibulo-autonomic connections, uh, are important as far as the tenth nerve is concerned, because the tenth nerve is a major parasympathetic output. Then comes the 11th nerve. The vestibulocochlear nerve has a intimate connections with the vestibular nuclei, have connections with the cervical muscles, especially the sternocleidomastoid and even the other cervical muscles. That is the reason why in many patients you will observe that when many patients with vestibular disorders, they have neck muscle spasm, which is an associated symptom because of the diseases in the vestibular system. So just in next time when a patient with vestibular neuritis comes, just observe one thing. Just try to ask the patient whether he's feeling the neck pain and which side the patient is feeling. And you will observe that on the same side of the neuritis, you will find that patient has stiffness in the neck. So it is not the neck pain which is causing the vertigo and dizziness. It is the reverse thing. That is, the vertigo and dizziness is leading to the activation of vestibulocolic reflex. Uh, that leads to the spasm of stiffness of the neck muscle. So that is actually the reverse way. And basically, when the vestibulo-ocular reflex is not working, the body is trying to compensate by activating the other reflexes which are not active that much. That is vestibulo-colic reflex. And that is the reason why the neck muscles undergo spasm in patients with vestibular migraine, vestibular neuritis, a variety of other vestibular disorder, and that leads to a false diagnosis of cervical vertigo and dizziness. And these patients get treated with neck therapies. Of course, the neck therapy helps for the neck pain, but we need to treat the underlying vestibular disorder. There should be it is very important that we should try and find out the underlying disorder before labeling the patient as cervical vertigo. Then comes the vestibular spinal tract. That's the way the vestibular system decides the motor output which is required for maintaining the equilibrium. The tone of anti-gravity muscles, the flexors of upper limb, the extensors of the lower limb, the truncal muscle tone is decided by the vestibulospinal tract. So all these tracts, the lateral corticospinal tract, vestibulospinal tract, they converge their neuronal output on the anterior horn cells, and they each of them give their inputs to the anterior horn cell, and the anterior horn cell, according to the higher inputs, decides the ultimate tone, mm, which muscle will contract, which muscle will relax. That is decided by the output which is coming from higher centers. So that's why in case of Meniere's disease, suddenly what happens is suddenly there is alteration of the vestibulospinal impulses which are coming to the anterior horn cells, and the sense of verticality, the sense of the posture suddenly alters, and the muscles try to adjust according to the altered sense, and the patient falls down suddenly without any premonitory symptoms. Suddenly patient can get drop attacks in patient with Meniere's disease. That happens because of sudden alteration in the vestibular tone, which is going to the spinal nuclei, that is anteron cells. Then comes the other sensory modalities like vision, proprioception, and vestibular system. So these three systems are hierarchical. There is a hierarchy in the arrangement of this. Whenever we are standing, we need visual input for our balance. Like when we are standing, we should be aware of the external things that is given by the vision. Even if we close the eyes, we can still maintain our balance because of proprioceptive inputs which are coming from all the joint receptors. And the last, once the vision is denied, once the proprioception is taken off by asking the patient to stand on a foam and not on a firm surface, then comes the role of, then we can elicit the vestibular system. Purely we are testing the vestibular system by asking the patient to stand with closed eyes on a foam. So this is the hierarchical arrangement of these sensations. And cerebellar functions, all these three inputs are these they go to the cerebellum, and cerebellum evaluates each one of them and compares with each other. Like it will compare the visual input which is coming from the tectocerebellar tract. It will compare the proprioceptive input which is coming from the olivocerebellar tract, and it will compare the direct and indirect vestibulo cerebellar like fibers which are coming from directly from the vestibular system, like semicircular canals, as well as indirectly through a relay at the vestibular nucleus. So these three inputs, the cerebellum matches, and once the cerebellum is sure, okay, all the inputs are matching, that's how there is no vertigo, there is no sense of vertigo and lack imbalance, sense of imbalance. When there is altered signals which are coming from visual versus vestibular or visual versus any of these three systems, then the cerebellum, then it creates a sense of imbalance or dizziness or vertigo. So this is what I was talking about. Recently, the Barani Society has come up with the classification of vestibular symptom, that is vertigo, dizziness, vestibular visual symptoms, and postural symptoms. The vertigo is was earlier regarded as a sense of rotation, but according to the newer classification, any sense of self motion when there is no movement. Suppose when I'm standing, sitting, and I'm feeling that I'm moving, that is a vertigo. And sense of distorted movement. Suppose I move my head, I should feel that my head is turning to the left, for example, now. But if there is a distorted sense of this movement, it is also called as vertigo. So that is about vertigo. And dizziness is, there are many patients you will observe. You just observe your next patient of vestibular neuritis. In the initial 2-3 days, patient will complain of severe vertigo. And later on, the patient will say that I feel disturbed. They are not able to explain that symptom. That symptom is dizziness. Like they have a sense of disturbed or impaired spatial orientation. That is dizziness. And this is commonly seen in even in vestibular migraine. We can see this. So dizziness earlier was considered, according to the American literature, dizziness was umbrella term, which included vertigo, syncopal dizziness, and other varieties. But Barani Society, European like literature from the beginning had a distinction between vertigo and dizziness, and they have come up with a classification, and they have clarified that this dizziness is not an umbrella term, and it is one of the vestibular symptoms, second type. One more thing I would just like to highlight. I just told that vestibular neuritis, next patient, just check. Initial days they will have severe vertigo. Later on they will have dizziness, and later on, if they are uncompensated, you will find that these patients develop vestibular visual symptoms. First, I will explain these vestibular visual symptoms. Patients will have a sense of movement of the surrounding. So when a patient says that they are rotational feeling, ask them whether they are feeling it on closed eyes also. If they are feeling after closed eyes, it is called as internal vertigo. This is again another new terminology or new thing which the Barani Society has come up. And when we open the eyes and the patient feels the sense of spinning or any movement, then it is called as external vertigo. So external vertigo is movement of the surroundings, and movement of self is vertigo, internal vertigo. By default, the vertigo means internal vertigo, and external vertigo gets classified as vestibulovisual symptom. Oscillopsia means shaking of the environment. Visual lag means when we turn our head, and some patients will tell that when they move their head, there is lag of the visual scene, and they get clarity after a few seconds. So that is visual lag. Visual tilt is they feel that the visual surroundings are tilted. And next is movement induced blur. That movement, any movement causes blurring of vision. So very common symptom in patients with vestibular migraine. So mainly these vestibular visual symptoms are very common in patients with vestibular migraine, as well as there are other pathologies which can lead to these vestibular visual symptoms. And these patients commonly consult ophthalmologists. Uh, they will go to an ophthalmologist because it is something happening in the vision. So it's very important that like these patients usually have some underlying vestibular disorder, could be vestibular migraine. So vestibular disorders can cause visual symptoms. It's very important to remember. And this is I was talking about when in the steady state also, when the subject is lying down, sitting, or standing, when there is no movement, during that time also the vestibular system is at work, and it is trying to maintain a sense of no vertigo or no vestibular symptom. It is because of the continuous work by both sided vestibular system in symmetrical and opposite way. That's why we don't have a sense of unsteadiness, dizziness, vertigo during the steady state. So it is something like cardiac pacemaker activity. Like we are quite aware that the heart has a pacemaker activity, electrical activity, and continuously the heart is pumping. And because we feel the heartbeats, we know that we can feel the pulse. We know that the heart is continuously functioning. But at the same time, the same thing like applies to the balance. Continuously, there is electrical activity which is going on in the brainstem nuclei, that is vestibular nuclei and vestibular connections, and there is a continuous there is a baseline vestibular tone which helps in maintaining the balance even in the steady state. And during the active movement as well as in the passive movement, as a driver, as a passenger, also there is a vestibular activation. It's not that the vestibular system comes into play only during movement. During steady state also there is a baseline vestibular tone which is helpful, which is very important so that we don't have a sense of dizziness or any other symptoms. And during head movements which are not in relation to the gravity also, there is activation of vestibular system. And of course, during the positional changes, there is typical activation of typical like for example during this rising up from the bed or lying down, there is activation of vertical canals. Turning in the bed in the supine, lateral canals, and even the earlier head movements I have shown in the sitting position, there was their activation of lateral canals. And especially when we bend down and lean and bend, there is activation of vertical canals. So coming to the central vestibular structures, which we grossly deal with, or we try to localize the lesion, is brainstem, cerebellum, vestibular connections, and the vestibular cortex. So these are the four important localization areas whenever we talk of central vertigo. These are the structures which can get involved and can lead to central vertigo. So as we know that when the semicircular canals get involved, BPPV, localization is in BPPV, otolith organs, otolith dysfunction, endolymphatic sac, Meniere's disease, vestibular nerve or ganglion, vestibular neuritis. Similarly, the localization in the central vestibular system is either the vestibular nuclei or the connections which are present in the midbrain, pons, medulla, or the involvement of cerebellum, or there are certain pathologies in which it can involve the vestibular connections with the cortex or the vestibular cortex, and that can lead to a sense of vertigo or dizziness. That was about the organization, the gross organization of vestibular system. Now I will go to the spectrum of central vestibular disorders. I have divided the central vestibular disorders into based on etiology, based on clinical syndrome, based on prevalence, based on the triggers, and based on the associated symptoms. The first is based on the etiology, how we divide the central and peripheral vestibular disorders. Coming to etiologically, if you this mnemonic we learnt in the UG days because it's a very handy mnemonic for any disorders for that matter. For example, vitamin D. If you classify any disorder into this vitamin D, you will find out that you can get so many disorders. For example, uh, if we classify disorders in this mnemonic, V stands for vascular, I stands for idiopathic inflammatory, T for trauma or toxic, A stands for autoimmune, M stands for metabolic, I stands for again infective, N for neoplastic, D for degenerative, G for genetic, and O for other. So similarly, I try to classify all the vestibular disorder in this mnemonic so that it is very easy to remember, and it's very important to remember their etiology, etiopathogenesis. So if we look at the with this mnemonic, the V, let us go with one by one. V stands for vascular disorder, so one by one we'll go. The blue font indicates the peripheral disorder, red font indicates central, and the black is a mixed one. Sometimes these disorders can present as peripheral, sometimes central. So if we look at the vascular disorders, majority of them will present are central and vestibular paroxysmia, because there is involvement of like vestibular nerve. The compression happens on the vestibular nerve. It is a peripheral vestibular disorder. So let us look at each one of these disorders. Like first, let us go to the stroke. So what are the different types of strokes? Basically, stroke is a clinical diagnosis. Clinically, when we call a patient has stroke, when a patient has sudden onset focal neurological deficit due to vascular cause, it is called as stroke. The stroke can be ischemic in 68 to 80% patients and hemorrhagic in 20 to 32% patient. If we do a CT scan after 24 to 48 hours, there will be hypodensity in case of ischemic stroke. In case of hemorrhagic stroke, there will be hyperdensity in case of hemorrhagic stroke. It could be most common cause is hypertensive hemorrhage, but there are of course other causes. Uh, it also could be hemorrhagic stroke also can happen because of subarachnoid hemorrhage. Subarachnoid hemorrhage is seen in 5% cases, less than 5% cases of stroke. So this is in the posterior circulation. This is how it will look in if it is but CT it is obtained within the window period. If we have to do an imaging and if you are sure of the stroke, you do a CT. If it is normal, you can go ahead with thrombolysis. But if it is out of the window period, you have time, you can go for MRI. If there is facility for MRI during the window period also, it can be done, but few images only can be done. Like for example, diffusion weighted FLAIR images are important because MRI takes more time as compared to the ischemic, as compared to the CT brain. So coming to the so in hemorrhage, what happens? There is a rupture of blood vessel. In infarction, what happens? There is a formation of clots which blocks the artery and it leads to the infarction of the area which it supplies. So, stroke, every 45 seconds, someone has a stroke, and every 3.1 minute, someone dies of one stroke. That is very important, and that's why worldwide stroke is the second most common cause of mortality and third most common cause of disability. That is the reason why identification of a stroke in a patient with vertigo is very important. That's why that question comes, whether it is central and peripheral, especially it comes in acute setting, and it is applicable in other, like in chronic also. It's very important to differentiate central cause from peripheral cause. And in general, we divide it's very important to classify stroke. A majority of, if we compare is stroke, ischemic stroke with cardiac myocardial infarction. In myocardial infarction, it is a monosymptomatic illness. Chest pain is the major symptom, but in case of stroke, it can have variety of symptom based on which location the stroke patient has, and it can present as a monosymptomatic vertigo also. That's why it's very important to know what are the central signs, what are the common accompaniments, common symptoms, signs which can accompany a particular symptom. And the patients can get large artery atherosclerosis leading to stroke, or cardioembolic stroke, like patient can have a atrial fibrillation with a thrombus leading to embolism. Patient can have small vessel disease like lacunar infarction. Patient can have other determined etiologies like hypercoagulable state like sickle cell anemia or other prothrombotic states. And another thing, last one is undetermined etiology. Despite of investigation, thorough investigation, many a times, 30% of the times we find that there is no detectable cause like one of these, and then we label it as stroke of undetermined etiology according to the Toast classification. So in large artery atherosclerosis, what happens essentially is there is a thrombus. For example, there is atherosclerosis, there is a plaque which becomes unstable. This plaque becomes unstable, and there is a rupture of the plaque, and then immediately the platelet aggregate forms and forms the thrombus, and that thrombus uh, can be artery to artery embolism. For example, carotid artery atherosclerosis can lead to artery embolism, or it can be occlusion of, suppose this thrombus is located in middle cerebral artery or anterior cerebral artery, that can be a large artery stroke. Or it can be a cardioembolic stroke. The embolus can originate from the heart and can go up, and it can lead to embolic stroke. Usually embolic stroke is involves different territories. It can at the same time can go into the any circulation, anterior circulation, posterior circulation, and it can lead to stroke. So basically, we have four vessels going into the brain. Two anterior, say, carotid arteries, internal carotid arteries, and two vertebral arteries. So these are the four arteries which are entering the brain and supplying the brain. Anterior circulation is formed by the internal carotid artery branches, that is anterior cerebral artery and middle cerebral artery, and the posterior circulation is formed by the vertebro-basilar system. So ischemic stroke treatment, I just I'm trying to create awareness about this intravenous thrombolysis, because it's very important that as soon as the patient develop stroke symptoms, they should consult, immediately go to a center where this thrombolytic treatment can be offered. It's very important not to delay the diagnosis, and it's not that there is a window period is 3 hours or 4.5 hours. That means it's okay to if the patient comes within 5 minutes, every second 30 around 33,000 neurons can die. So earlier we treat the patient, better is the outcome. That's very important. It's not that 3 hour window period. The If we thrombolize at 1 hour versus 3 hour, the benefits will be more at 1 hour as compared to 3 hours. So it's very important that earlier we do the treatment, and these are the variety of options in the patients. And this is what I was talking about, the posterior circulation. The two vertebral arteries join together to form the basilar artery, and there are branches of coming from posterior inferior cerebral artery is a branch from vertebral artery, and anterior inferior cerebral artery from the basilar artery. And there are circumferential branches from the basilar artery, that is short circumferential and long circumferential branches which supply the pons and the brainstem structures. And there is superior cerebellar artery which is very important, which supplies the midbrain. And this is very important diagram where the basilar artery gives this anterior inferior cerebellar artery, and anterior cerebellar inferior cerebellar artery gives this internal auditory or labyrinthine artery, and labyrinthine artery then divides into anterior vestibular, posterior vestibular, and cochlear. So these are this supplies the sometimes what can happen is infarction can happen alone in the labyrinthine artery, and it is an end artery. So there are certain etiologies like fat emboli, thromboanginitis obliterans, migrainous infarction, decompression illness, hyperlipidemia, microglobulinemia, sickle cell disease, leukemia, polycythemia vera, and hypercoagulable states, which can specifically cause this thrombosis of labyrinthine artery, and there can be isolated infarction of like the vestibule and the cochlea, and patient can present with sudden onset vertigo, acute vestibular syndrome, along with sudden onset deafness, hearing loss. So it's very important that like in these cases, it's very difficult to differentiate it from whether it is due to an inflammatory cause like a neuritis versus it is due to the vascular cause. But there are, of course, there are certain clues which I'm going to tell. So that is very important. But usually the infarction happens in inferior cerebral artery, and there are in patients with anterior inferior cerebral artery infarction, there are many eye signs which can help the patient. Like I will discuss about that. And if we want to differentiate between different territories, posterior inferior cerebral artery, anterior inferior cerebral artery, or superior inferior cerebral artery, there are certain like parameters. Like for example, isolated vertigo can happen in posterior inferior cerebral artery. Canal paresis is common in ICA because it can involve the vestibular cochlear nerve nucleus, and it can cause canal paresis. There can be pathological head impulse test in anterior inferior cerebral artery infarction. Hearing loss is common. Audiovestibular together acute audiovestibular loss is common. Gaze evoked nystagmus is common in patients with central. It's very important to check for gaze evoked nystagmus. And severe postural instability is a very common sign which is seen in patients with central vestibular disorders as compared to the postural, as compared to peripheral. But one caveat is there during the beginning of any acute peripheral disorder, even peripheral like vestibular neuritis, on the first day of presentation, they are also not able to walk. But it's very important to check. There are certain, it's not only one sign will help you to differentiate between central and peripheral. It is a combination of signs which will help in differentiation. So many a times this question is asked in conferences: tell me one sign which can differentiate central and peripheral. It is not so easy. It's very important that the vestibular vertigo can happen due to involvement of brainstem anywhere in the brainstem and cerebellum. So wherever it is happening, then we have to look for associated symptoms and signs. And this is about the radiological identification. If it is the involvement of midbrain, uh, then we have to think of in and superior cerebellar peduncle. That is a territory of superior cerebellar artery. If there is involvement of in and radiologically, if you see an infarct and there is involvement of cerebellum along with pons, then it is mostly at the territory of anterior inferior cerebellar artery. If there is involvement of medulla and cerebellum, usually it is a territory of the pica, posterior inferior cerebral artery. And that's why the identification of these brainstem structures is important first. Then we can accordingly decide whether which territory is involved. Even before the angio, we can see that these if there is involvement of these structures along with cerebellum, we can tell which vascular territory can be involved. Now coming to vertebro-basilar insufficiency, this is the V1 segment of the vertebral artery. After arising from first part of subclavian till it reaches to the vertebral foramen of C6, it is a V1. V2 is from vertebral foramen of C6 to C2 is V2. V3 is after it comes out of C2 and it pierces the dura mater here. It is V3 segment of the vertebral artery, and the V4 segment is nothing but after piercing the dura mater, then it reaches and joins the other vertebral artery. That is where the vertebral artery ends and forms the basilar artery, when the two vertebral arteries join together to form the basilar artery. So these are the four segments of vertebral artery, and there are certain disorders which are common in these different parts of the vertebral artery. For example, occlusion or stenosis of subclavian artery proximal to the origin of vertebral artery is common in patients with subclavian steel syndrome. V2 is the most common site for vertebral artery dissections. Dissections whenever the patients, because of chiropractic maneuvers, because of head injury, because of trauma, road traffic accidents, whenever there is vertebral fractures, it can lead to dissections of the vertebral artery, and it can lead to vertebrobasilar stroke, ischemia. So this terminology basically like it's in another 1 or 2 months time, Barony Society is coming with a terminology called vascular vertigo instead of terminology, the other terminologies, and we should better call it as a vascular vertigo than vertebrobasilar insufficiency. Site of compression, this is the V3 is the common site of compression in patients with rotational vertebral artery syndrome or a Bow-Hunter syndrome. And V4 segment of the vertebral artery can compress the brainstem, like that is the medulla oblongata, and it can lead to something called as this again that there is little controversy on this term. It should be like a vascular brainstem compression, uh, but Professor Louis Kaplan during his first article in the his article mentioned this as vertebral artery compression syndrome. But recently, the Barany Society has named this rotational vertebral artery syndrome with a newer term called vertebral artery compression syndrome. So there is little controversy in this terminology, but we should brainstem vascular compression we can remember for the time being, and definitely the Barany Society will come up with a terminology for this syndrome also. And the site for basilar artery occlusion is the basilar artery proper. So coming to one by one to the syndromes which I discussed about, the brainstem vascular syndrome. What happens is, as you can see, the brainstem, like the medulla oblongata, is distorted, displaced, or because of the vertebral artery. This is a vertebral artery, and which is displacing the medulla oblongata. We can clearly see the displacement of the medulla oblongata, and I have a series of around 20 patients of suffering from this particular syndrome, out of which 8 patients are symptomatic. In the symptomatic patient and asymptomatic patient, in the Barany Society meeting next month, I'm going to present this abstract. What were the differences between asymptomatic and symptomatic patient? And unfortunately, this is very less recognized cause, like of transient ischemic attacks happening in young people. Young people get transient ischemic attacks like monosymptomatic vertigo. No, majority of patients will have different symptoms like numbness of the face and numbness of the arms and the legs, dragging, a sense of dragging sensation on the face, sense of like some patients can feel little dysphagia or blurring of vision, double vision, and it's very important to recognize this particular syndrome and identify and start them on just aspirin. Just starting them on aspirin helps. It is not something like vestibular paroxysmia where we give carbamazepine. It is a compression of a brainstem, which is a neural, which has a subarachnoid space, and basically the artery is compressing the another artery, small arteries which are supplying the brainstem, and that is leading to transient ischemic attacks. And in case of vestibular paroxysmia, the artery is compressing a nerve where there is generation of impulses and it leads to vertigo. So the mechanism is different, so the treatment is different. And this is my series where the age range was 29 to 62 years, and all the patients had transient ischemic attack. One patient had infarction, and even in patients with normal caliber artery, this particular thing can happen. Normal caliber artery also can compress the brainstem and can lead to this particular transient ischemic attack. And just me starting the treatment with aspirin or clopidogrel is enough to prevent the attacks. Of course, some patients might need dual antiplatelet based on the severity of symptoms. And this is what I got, like sensory symptoms on the face, one-sided face and one-sided body, and weakness. Some patients even complained of weakness of hands, leg, and many a times these patients are considered as suffering from functional disorder. Young patient coming with vertigo and these motor symptoms, sensory symptoms, and majority of the times they are labeled as you don't have any issues, MRI is normal. If this thing doesn't get reported, what happens is these patients can be missed and treated for like some other cause like vestibular migraine or some other cause, and that leads to it can lead to a stroke in these patients in future. So it's very important to recognize this entity. And just in short about the subclavian steel, what happens in subclavian steel is there is occlusion of first part of subclavian, therefore there is change in the circulation, and whenever the patient performs the forearm exercise, the patient can get transient ischemic attack, and this is rotational vertebral artery syndrome. So I will just quickly go through the spectrum because we have completed around 50 minutes. So if required, there are a lot of things in this, so I'm going slow because it's very important to cover everything rather than rushing into things. So infective etiologies, if we look at the infective etiologies which can affect the vestibular system, these are the various things like herpes zoster, acute and chronic bacterial infection, syphilis, Lyme disease, HIV. So syphilis is relatively rare now. Lyme disease is not common in India, acute and chronic, but it is common in European countries, and it can be seen in Western world. And acute infection, bacterial infections of the vestibular system can happen in children. Herpes zoster can happen, but due to reactivation of latent virus, and it is one of the most common cause of infective etiology, and it can lead to involvement of the vestibulocochlear nerve as well as the facial nerve. And there, it's very important to examine the for ear vesicles in the external ear. In all patients with facial palsy, I make sure that I check for the vesicles in the ear. And even in patients with vertigo, it's very important to check whether they have a partial form of Ramsay syndrome. Then comes the toxic traumatic etiology. Drugs and toxins are common cause of vertigo and dizziness. Head injury can cause concussion, labyrinthine concussion, cerebral concussion, and can cause dizziness, vertigo. Head injury can also cause dissection of vertebral artery and can lead to a posterior circulation stroke. A head injury, I have commonly seen patients with head injury coming with headache and vertigo. Post-traumatic migraine is very well known, but I'm going to present one article on post-traumatic vestibular migraine. I have seen patients with head injury, in which the scan is normal, but the patients keep complaining about vertigo and they don't have BPPV. Post-traumatic BPPV is common, but if we rule out BPPV, very important cause is vestibular migraine, which can start after the head injury. Uh, and recently, after the pandemic, I have noticed many patients post-COVID they develop vestibular migraine. Post-vaccination patients can develop vertigo, which could be related to the vestibular migraine. So post-COVID migraine is we have seen many patients developing who had mild migraine in the past or no migraine in the past and developing migraine after the COVID infection. Patients can after vaccination also can present with vertigo, and which one of the reason could be vestibular migraine. Of course, the other things which we need to consider, other vestibular disorders also we need to take into consideration. After ear surgery, patients can develop a variety of things and can lead to vertigo. Barotrauma can lead to some disorders. Chiropractic maneuvers can lead to dissection, vertebral artery dissection. Alcohol can cause ataxia, positional nystagmus. Chronic alcohol intake can lead to thiamine deficiency, and vestibular symptoms are very common in thiamine deficiency. Alcoholic people, patients can lead to head injury because of influence of alcohol. Head injuries are very common in after alcohol intake. Third window syndromes like superior canal dehiscence, perilymphatic fistula, and other things can also this comes into traumatic and toxic causes. Then the next comes the autoimmune disorders. Autoimmune disorders mainly involve the peripheral vestibular structures. Majority of them causes peripheral audiovestibular loss, but some of course can involve the central vestibular structures also. Then comes the M stands for I instead of metabolic, I change into migraine mania spectrum, because it's very important like to differentiate vestibular migraine from Meniere's disease. And it is a spectrum where pure Meniere's disease is at one end, and pure vestibular migraine is at another end of the spectrum. And there are many patients who satisfy the criteria for both. Some patients satisfy, but by and large, vestibular migraine, if we look at vestibular migraine, it is 20 times more common as compared to Meniere's disease. So it's very important before going for any surgical or any invasive procedure. It's very important to look at the history of the patient and rule in vestibular migraine before considering the surgery or invasive treatment for Meniere's disease. And what happens majority of times in patients with vestibular migraine, it is a central vestibular disorder, one of the most common central cause of vertigo. There are certain central signs which can be seen during the attack, but majority of times it shows peripheral vestibular signs like nystagmus, which is present without fixation, and which is pure variety like pure upbeating, pure downbeating nystagmus without fixation. That creates a lot of confusion, and the imaging comes normal. So patients with vestibular migraine, majority of the patients like there is it's a clinical criteria which is very important in the diagnosis and the tests. Rather than helping, many a times they confuse the imaging is normal, the patient has pure updating nystagmus without fixation. So it creates a lot of anxiety, and patients even they keep consulting different doctors. They are treated as cervical cause, because vestibular migraine can also cause the neck stiffness and neck pain. Coming to inflammatory idiopathic etiology, multiple sclerosis is a very important cause in which there is a dissemination in space of the plaques can involve different areas. There are four areas: juxtacortical, periventricular, and the brainstem and spinal. These four areas can get involved in different times. Different times they can get involved, these areas. And the cerebellum, these are the various structures which can get involved in MS. And in 5 to 10% patients, the patients can present with vertigo as their presentation. If the MS plaque involves any of these structures, the patients can present with vertigo. And there are three syndromes. Like I personally, like in my registry, patient can present with an acute attack of MS in brainstem and cerebellum, and it can be a pseudoneuritic presentation. Patients can have paroxysmal brainstem attacks later on after the recovery of. One patient had the plaque in the root entry zone, and this patient presented later to me with paroxysmal brainstem attack similar to vestibular paroxysmia. It is a, it was not a vascular compression, but it was it was happening because of the ephaptic conduction due to damaged vestibular fibers, and carbamazepine helped in this patient. And even I have seen patients with typical neuritis in patients with MS without any brainstem plaque. So whether the MS is involving the causing demyelination at the root entry zone of the peripheral nerve, and that is something which needs to be investigated. But I have seen two patients with vestibular neuritis without any plaque in the brainstem. Then coming to the neoplastic, like there are variety of tumors which can involve brainstem and cerebellum, and paraneoplastic syndrome, which can lead to vertigo and dizziness. Usually, brainstem tumors can lead to vertigo and dizziness if it is acute presentation. But if a tumor like CP angle tumor develops subacutely or chronically, usually the vestibular nerve lesion gets compensated, and the patients usually don't develop vertigo. So in vestibular schwannoma, although the tumor originates from the vestibular nerve, it is a slow growing. If it is a slow growing one, it will the vestibular deficit will get compensated, and the cochlear divisions when starts get involving, the patients start developing the hearing loss and tinnitus. Vestibular nerve can 61% patient can have mild imbalance, mild to moderate, which they are like they may not be aware of. And mainly they can like they tell about the hearing loss and tinnitus. And true spinning vertigo is uncommon, because true spinning vertigo is something which is related to the acute vestibular disorder. Central symptoms and signs starts appearing when there is a compression of brainstem. And signs in CP angle tumor, Brun's nystagmus seen in 11% in the tumor when the tumor is larger than 3.5 centimeter. Trigeminal sensory loss is seen in less than 17% patient when we check for the sensory loss on the forehead. Head shaking nystagmus is seen in 22% patients, but there is one sign which is very important and which is seen in 82% of patients, that is hyperventilation induced nystagmus, which is seen in 82%. So what I will do is just a minute. I'm getting one call, probably from organizers, I think. Hello, hello, हाँ, हेलो, हाँ हाँ, कोण बोलतंय? हाँ, मी थोड्या वेळात एक फोन करू का? या थोड्या वेळात करतो. हां, ओके. So, because like 1 hour is over, because it's a very vast topic, what I will do is I will just complete in few slides the spectrum of central vestibular disorder. But I would like to complete like this, because rather than hurrying into the all the slides, what I will do is differentiation between central and peripheral vertigo. We will keep for the next, and I will start presenting cases from the next talk. But I will just complete this spectrum in a while. So coming to the degenerative and developmental disorders which can affect the central, the vestibular structures is Arnold-Chiari malformation, spinocerebellar ataxia, enlarged vestibular aqueduct, otosclerosis, and Mondini syndrome. These two are central. And in Arnold-Chiari malformation, what happens is there is herniation of cerebellar tonsil. There, it can be associated with the serrings in the cervical spinal cord. There can be corpuscallosal abnormalities. Uh, and the medial, what happens is there is a compression of the cerebellar tonsil and the brainstem at the level of this cervicovertebral junction. And there can be variety of symptoms like pain in the occipital or cervical region, and arms, double vision, blurred vision, oscillopsia, seizures. Developmental seizures can happen because of cortical involvement. Developmental delay also happens because of the cerebral involvement. There are four types of Arnold-Chiari, the most common being the Arnold-Chiari type 1. So very important not to miss this in patients with chronic vestibular syndrome. Spinocerebellar ataxia, as the patient can present with chronic insidious onset, gradually progressive imbalance of gait, along with poor coordination, speech abnormalities, nystagmus, dysphagia. Genetic causes are very important. One is episodic ataxia type 2, which can mimic like vestibular migraine. It can be treated as vestibular migraine, but it's very important to differentiate episodic ataxia type 2, canvas syndrome, charge syndrome, Usher syndrome, and familial vestibulopathy. These are the variety of features which are seen. Special mention I would like to mention about the episodic ataxia type 2, which is a common one. Patients can present with paroxysmal attacks of ataxia lasting hours with vertigo, dizziness. Headache is also there. That's why it can get diagnosed as vestibular migraine. Patients can have oscillopsia. Minor myasthenic symptoms can also be there in some patients. Central ocular motor dysfunction and nystagmus is there, and it can be provoked by exercise, sports, stress, alcohol. Age of onset is late childhood. Interictal findings can be cerebellar ataxia, downweighting nystagmus, minor myasthenic signs, and the MRI can show cerebellar atrophy of the vermis, cerebellar atrophy, or even the atrophy of the lobes. EEG can show dysrhythmia, EEG abnormality can be seen, and it is a very slowly progressive ataxia. And there are certain drugs which can be helpful, like pamperidine and acetazolamide. So it's very important to be aware about this disorder whenever we are considering patients with vestibular migraine. And the other disorders are BPPV and light pupilla and vestibular atelectasis are the peripheral ones. And the central ones are Wernicke's encephalopathy. It's a very important central vestibular disorder in patients with thiamine deficiency. Cerebral hemispheric lesion can also sometimes cause vertigo. For example, a neurocysticercosis or a focal lesion happening in vestibular cortex like insula. It can cause vertigo, and it can cause it is one of the important cause of central vestibular disorder. Hypothyroidism can cause reversible cerebellar ataxia. It's very important to, if a patient presents with subacute cerebellar ataxia, imbalance of gait, very important to check the vitamin B12 level also. And it can, thyroid also, it's very important to check, because patients with hypothyroidism can develop reversible cerebellar ataxia. Epilepsy, there is one epilepsy called as tornado epilepsy, in which the vertigo happens as an aura symptom before a seizure. But by and large, all patients will get a seizure. It is not that patients will present with isolated vertigo in a patient with epilepsy. Patients will develop loss of consciousness and typical seizure symptoms. And there is one entity, these are the various nuclei which can get involved in patients with Wernicke's encephalopathy. That is nucleus prepositus hypoglossi. Medial vestibular nuclei can get isolated involvement of this sixth or seventh nerve, isolated involvement of the periaqueductal gray matter, midbrain, thalami can happen. And these patients can also have involvement of the these vestibular connections and vertigo they can present with. Uh, So it's very important to remember one thing, that patients with Wernicke's, the thiamine deficiency can present with bilaterally abnormal horizontal head impulse test and pathological gaze evoked nystagmus without encephalopathy. And after thiamine replacement, there is immediate resolution of symptoms in many patients. It's very important to recognize this entity, and if it goes unrecognized, just imagine the suffering of the patient. Just a mere injection of thiamine or a tablet of thiamine can lead to a complete resolution of symptoms. But these patients can go on suffering, and they can develop bilateral vestibulopathy. And usually it happens in patients with chronic alcoholism, gastric bypass, but it can be sporadic without this history. And there is one entity called as cerebellar dizziness. There was one article where they have clubbed all the cerebellar etiologies into this, into this umbrella term called cerebellar dizziness. And there are variety of things which can involve the cerebellum and can lead to cerebellar dizziness, like idiopathic downbeat nystagmus syndrome. I have recently come across with a case of idiopathic downbeat nystagmus syndrome. And these are the variety of things which can involve cerebellum, like isolated mild cerebellar ocular motor disturbance, Arnold-Chiari malformation, MSAC. Patients can have positional nystagmus in MSAC. I have seen recently one patient who had positional downbeat nystagmus in this MSAC, canvas syndrome, idiopathic downbeat nystagmus, spinocerebellar ataxias, and other varieties of disorder. So this completes the central spectrum of central vestibular disorder based on the etiology. Even we have not gone to clinical syndrome prevalence triggers. That I think it's better I stop here and I take questions on this. And we will in the next anyway we are going to conduct this particular activity every month, mostly on every Saturday, first week Saturday, 6 p.m. GST, like the current what time, like 7:30 p.m. in India. And we will continue with because these things are very important. We should go in detail about all these central vestibular disorders, because that is a common concern, where how to differentiate. And next time we will definitely discuss the rest of the parts of my lecture. And differentiation between central and peripheral is very important, so I request everyone to attend the next time and tell to your colleagues also. Here I will stop, and Dr. Sriharsha, if you are there, or I can take the questions. Like if anybody wants to ask the questions, you can either type in the chat box, or you can unmute the audio and you can interact. Dr. Sriharsha, if anyone wants to ask questions, you can unmute yourself and ask questions, because it's a very important topic. Day to day, we get patients with vertigo and dizziness, and it's very important to differentiate between central and peripheral. Today, I just presented only the spectrum broadly. In subsequent lectures, we are going to discuss. I will focus in next 3-4 talks. I will focus mainly on the central vestibular disorders, the variety of presentations. So if let me see if there are anything in the chat box. If anyone wants to ask questions, you can unmute yourself. Okay, so there are certain comments. Thank you, Dr. Ganesh, Dr. Chaudhary, Dr. Eugene. Thank you so much. Dr. Chaudhary has written, I had a SCA with CSOM. Yeah, it can happen. So, SCA, maybe you can unmute and share your interesting case with us. You can pre-op vertigo, but diagnose later. Any warning signs? So, pre-operatively, the patient had vertigo, but diagnosed later. Any warning signs for SCA? Sir, can you please unmute and maybe you can elaborate your question? Okay, with this, I will try to answer. So, what Dr. Chaudhary has written is SCA with a CSOM. SCA I didn't get whether it was SCA, superior cerebellar artery stroke, or spinocerebellar ataxia. I don't know. So maybe preoperative vertigo. Of course, in certain surgeries, can lead to, like, post-operative vertigo can happen because of variety of reason. One is post-operatively immobilization can cause BPPV. Post-operatively, there are third window syndromes. Some issues can happen during the ear surgeries, especially. And one thing to remember is even the non-otologic surgeries, after non-otologic surgeries like dental extraction, dental procedures, even non-facial like surgeries, even the abdominal surgeries, there are articles on BPPV after non-otologic surgeries. So yeah, he has written now and he is unable to unmute. So yeah, so I will just try to like I'm trying to see the all comments. So the patient had spinocerebellar ataxia. It's very interesting case then. Spinocerebellar ataxia and underwent surgery. And so he must be having, usually patients with spinocerebellar ataxia will have a lot of cerebellar signs, and initially it's a gradual onset, and gradually they will progress, unfortunately, and they will have severe ataxia later on. How Dr. Eugene has asked, how would you classify a patient with positional vertigo on eye movements, not VPPV, born with fusion of C1 and C2, bedside examination normal, MRI, MRA normal, Doppler normal. Okay. Okay. If a patient has positional vertigo, okay, and it is not characteristic of BPPV, what Dr. Eugene has written, born with a fusion of C1. See, merely the fusion of C1, C2 may not indicate that that is the cause of the vertigo. There has to be like the herniation of the tonsils more than what is needed to diagnose the condition. So the tonsillar herniation should be there. That is one. And there should be other other features, like for example, in case of Arnold Chiari type 1, you might see syringes in the cervical spinal cord. There is cerebellar atrophy in later stages. So it's very important to have a discussion with the radiologist. I make sure that when there are certain patients with little tonsillar herniation without they don't qualify into the diagnosis of Arnold Chiari type 1. So it's very important to have a discussion with the radiologist regarding this thing, and discuss with them whether it qualifies as any of the craniovertebral anomaly, and is there any compression of the cerebellar structures in this fusion of C1 C2. It's very important that to see how whether there is involvement. Of course, the patients with involvement of the brainstem, cervicomedullary junction, can present with positional vertigo. And bedside examination in this patient, she has written normal, and the other reports were normal. So central positional, there is something called as central positional vertigo, which needs to be considered in patients who are not having characteristic features of BPPV. Like if the patient doesn't have a latency, if the patient has the characteristic nystagmus which is seen in BPPV. Suppose you get pure downbeat nystagmus, or a pure upbeat nystagmus, or a pure variety of nystagmus in patients with positional nystagmus. Of course, if it is not like BPP, like crescendo, decrescendo characteristic, there is no fatigability of the nystagmus. So these are the patients whom you can call as central positional vertigo. And the variety differential diagnosis of central positional vertigo is the most common being the vestibular migraine, but the other common causes are infarction in the brainstem can also cause positional vertigo, then CV junction anomalies, then tumors. Tumors also can cause positional vertigo. Demyelinating plaques in the brainstem in MS, multiple sclerosis, can also present as a positional vertigo. So it's MSSC. MSSC can present with positional vertigo. So these are the different diagnoses which needs to be considered, and merely finding some MRI finding may not be a cause of the symptoms. So it's very important that we have to look at associated symptoms, which syndrome the patient is classifying into, whether it is acute vestibular syndrome, spontaneous episodic vestibular syndrome, or it is a triggered episodic vestibular, or a chronic, is important. I hope I answered your doubt, but I'm going to elaborate on this in my next talk. Like I'm going to show the differentiation. Diagnosed an MRI with Crab sign. Does BPPV? I will talk about this Crab sign. Maybe I don't know about the Crab sign. Maybe next talk I will. Before next talk I will search and present this. Does BPPV, Dr. Anuja Reddy has asked, does BPPV cause drop attacks on getting up from bed in early morning? So when the patient gets up from bed early morning, patients can have severe vertigo. And of course, the patient can have little postural instability during the vertigo. But the drop attack terminology is specifically used for a patient who suddenly drops without any premonitory symptoms. If you look at and the new latest terminology for drop attack by Barani Society is balance related fall. And in a typical drop attack in Meniere's disease, or there are a variety of causes of drop attack. It is not that only Meniere's disease can lead to drop attack. There are two, three things which we should remember. One is drop attack, the patient doesn't lose consciousness. Second is there are no premonitory symptoms. In a patient with syncopal attack, patients will have premonitory symptoms. Patient will have little lightheadedness, blackout, sweating, uneasy feeling, nausea, and then they fall, and then they lose consciousness. That happens usually in syncopal attack. In patients with drop attack, they suddenly drop. If it is balance related drop attack, then suddenly they will fall. In patients with BPPV, if you do a repositioning maneuver, like if you do the treatment, if you do a canalith repositioning procedure, like for example in a posterior canal BPPV, you treat them with a please maneuver, patients can, after regaining to the last position of the Epley's maneuver, patient can suddenly feel like they are going to have a fall. It's very important that immediately after Epley's maneuver, let the patient sit there itself for some time. uh, Even if you make the patient sit somewhere else, it's very important to uh, like uh, even if the patient is denying that they can walk, it's very important that to give them support and let them sit for some time, because patients can have drop attacks after the treatment of BPPV. But early morning when they wake up in from the bed, they might have severe vertigo, and even they can feel a sense of imbalance. If they start walking, they can fall. That can happen. A 60-year-old lady had disulfide positive for posterior canal, but she gives history of giddiness in morning and drop attacks occasionally without loss of consciousness. Yes, it can happen. In elderly patients, BPPV can present with drop attacks. This is very important to remember. And it's very important to do positional testing. Thanks, Dr. Anuja, for bringing here this very important thing which can happen in elderly. This is one of the presentation in elderly. Thank you, Dr. Eugene. Then Dr. Eugene has again asked, would you refer to neurologist as he is not responding to common medication, vitahistine, cinnarizine, and amitriptyline? This is if it is in regard to the patient with the C1 C2 fusion. Yes, a neurologist must look at the patient, and it is a comprehensive like thing. Like for example, vertigo is something like we should collaborate. ENT and a neurologist should collaborate together, along with even a psychiatrist, cardiologist. It is very important to evaluate the patient thoroughly, especially in undiagnosed cases, like if there is no clear cut pathology. Patient strangely feels he is better with indomethacin. If the patient feels better with indomethacin, let's just check about the history of headaches. And if the headaches are short lasting, like less than 2 hours, there is something called as trigeminal autonomic cephalalgias, which specifically respond to indomethacin. This is a drug of choice for patients with trigeminal autonomic cephalalgia. But of course, this patient needs a thorough history. Maybe you can send it to me on my email about the details of the patient history, and then we can present even in the maybe in the next class we can present this case. It looks interesting. Thank you, Dr. Anuja. And I think there are no further questions because it's 7:25. We have another 2-3 minutes. If somebody has any questions, we can uh, like put into the chat box. Otherwise, we will just wind up. I'll just wait for a minute, and even I will wait for a signal from the boss. Uh, Dr. Sriharsha. If you don't have any questions, you may leave the meeting. And
Sir,
yeah,
Vishal, sir, thank you, sir. Thank you for the wonderful lecture. I was there actually because of today's festival, I was going on from place to place.
okay, okay,
Yeah.
okay. Okay. So, yeah, thank you so much, Dr. Sriharsha, for again starting this. Thank you for motivating me to start this again. And hopefully, we will not we will continue every month now here on.
Definitely.
And fortunately, I have a presentation ready for next month. So definitely, next lecture is for sure it is there, and I will keep this in mind and whatever cases are there. And in this 2.1 series, we will mainly focus. I will focus on the central vestibular disorders. So I request all the audience to tell your colleagues to attend. I think there are certain comments like Dr. Chaudhary, aphasia symptoms with vertigo. If the patient has, it's very important if the patient has speech disturbances it's very important to differentiate between dysarthria and aphasia because both are different. If the patient has language disturbance like problem in comprehension, problem in articulation, problem in grammar, then it is language problem in writing, reading, then it is a language disorder, aphasia. And if the patient has isolated slurring of speech, it is dysarthria. So if the patient has dysarthria with vertigo, yes, that can happen in brainstem and even in cerebellar the localization. Aphasia with vertigo is little less common because language disorders basically happen in cortex. Of course, it can happen if the patient has cardioembolic involvement and involvement of brainstem as well as cortex, these areas, language areas. Then Dr. Chaudhary is asking, where do you see the symptoms frequently of these aphasia symptoms? That's what I was like. These are the very right disorders in which you can see. Thank you so much for Dr. Chaudhary for active involvement. And thank you so much everyone for attending. Are there any announcement, Dr. Sriharsha?
So thank you, sir. Have a good night.
Yeah, good night. Thank you so much everyone.